All right, we'll get started. Hi, everybody. Thank you so much for joining us. This is session 5B, Tailoring Virtual Substance Use Care to the Needs of Equity-Deserving Populations, a Qualitative Participatory Research Study. My name is Sarah. I'm very happy to be moderating this session today. Before I introduce our speakers and we get going, I'll just give you a couple of reminders. If you would like to increase the size of the slide presentation, just right-click on the presentation image, select Picture in Picture, and then the window will pop out and you can resize it. During the presentation, you're welcome to put your questions and comments in the room chat, which you can open by clicking the chat icon at the top of the screen and selecting Current Room. And at the end of the presentation, you'll also be able to ask questions using a microphone by raising your hand. So with that out of the way, I am very excited to introduce our speakers for this session. First, we have Lise Dassieu. Lise is a health sociologist and qualitative researcher in the fields of substance use and chronic pain. She's currently a research and policy analyst at the Canadian Centre on Substance Use and Addiction. Previously, she worked as a senior postdoctoral research at the University of Montreal Hospital and at the University of Sherbrooke. She holds a PhD in sociology from the University of Toulouse in France. Lise has led many interdisciplinary research projects focusing on access to healthcare services for people who use substances. She's committed to working in partnership with people with lived experience through participatory approaches and to improving health equity for socially marginalized populations. Lise has published her work in major peer-reviewed journals and received the Ronald Melzack Canadian Journal of Pain 2021 Paper of the Year Award for her work on stigma and chronic pain during the overdose epidemic. Chealsea Moor is a knowledge broker with the Canadian Centre on Substance Use and Addiction. She's been with the centre for over 6 years. While she has been involved in a wide array of CCSA's work, her present areas of focus include community engagement, partnership management in equity, diversity, and inclusion. Chealsea holds a master's degree in forensic psychology from Carleton University. Her master's studies focused primarily on substance use and mental health needs of women involved in the criminal justice system. She is also a former employee of the Correctional Service Canada Research Branch Women Offenders Unit. And Jill Harnum is a regional peer lead with the Substance User Network of the Atlantic region. She partners with her husband in St. John's, Newfoundland to offer faith-based peer-led ministry to people who use or used substances and also those with various mental health challenges. She's passionate about educating those in the health and social service sectors, using her own lived experience with substances and her background in nursing to get the message across that people who use or used substances are worthy of the same treatment and respect as anyone else. Jill has been a peer researcher for the CCSA and is also part of an advisory group to the CCSA. So with that, I will turn it over to our speakers.
Thank you so much, Sarah, for the introduction, and thank you everyone for joining today. So we'll start. So I'm sorry, I just have to move the slides. Okay, perfect, that works. So we would like to start with a land acknowledgement. We acknowledge that the offices of the Canadian Centre on Substance Use and Addiction are located on the traditional, unceded and unsurrendered territory of the Algonquin and Anishinaabe people, who have been present on and nurturers of this land since time immemorial. As a national organization, we also acknowledge that we work on the traditional lands of many distinct nations, including Métis and Inuit, and we are humbled to have the opportunity to be present in this territory. We pay our respect and honor to First Nations, Métis, and Inuit as distinct people and as sovereign traditional knowledge keepers. By partnering, listening, and engaging during the sharing of traditional Indigenous knowledge, history, culture, and language, we may begin to understand the meaning of true connection to earth, air, water, ice, and all beings. We strive for respectful partnerships with all Indigenous people as we search for collective healing and true reconciliation.
And we also want to share, because this study took place in Newfoundland and Labrador, we respectfully acknowledge the land on which this qualitative participatory research study took place as the ancestral homelands of the Beothuk, whose culture has now been erased forever. We also acknowledge the island of Uktahunguk, colonially known as Newfoundland, as the unceded traditional territory of the Beothuk and the Mi'kmaq.
So for the disclosure, so we would like to disclose that this project has received financial support from Health Canada as part of the yearly funding of the Canadian Centre on Substance Use and Addiction for 2022-2023, and the speakers have no conflicts of interest. So we are all involved as employees or contractors with the Canadian Centre on Substance Use and Addiction. And we would like to say that CCSA is a non-governmental organization and trusted third-party expert on substance use and addiction. And CCSA is an independent, neutral, and non-partisan organization. And our work is rooted in scientific evidence and sound methodology. The funder had no role with respect to the result of this study and the content of this presentation, and this presentation does not necessarily represent the views of the funder. So that being said, we'll go on with the learning objectives and the background for the study.
Thank you, Lise. So by the end of this presentation, we hope participants will be able to understand how virtual care can meet the needs of equity-deserving populations who use substances, and understand how healthcare providers can develop virtual relationships that meet the expectations of this population. Also understand how virtual care can contribute to reducing stigma in healthcare for members of equity-deserving populations who use substances. And last but definitely not least, understand the benefits of involving people with lived or living experience of substance use in virtual care practices, policies, and research. Next slide, please. So the COVID-19 pandemic, as we all know, led to services and supports in the field of substance use to quickly adapt to a rapidly changing public health emergency. Many of these services and supports across the continuum of care made a partial or complete shift to virtual care. There have been several barriers identified by another study by Goodman et al. For members of equity-deserving populations in accessing substance use care, such as challenges accessing internet, digital literacy, lack of a safe or private space to access virtual care, and challenges building a virtual relationship with practitioners. Equity-deserving groups in this project refers to women, members of racial ethnic groups, people experiencing socioeconomic issues, and people living in rural or remote areas. In the field of substance use, there is a lack of qualitative research investigating virtual care experiences among members of equity-deserving populations. To foster digital health equity and support clinical practice, it is essential to qualitatively understand the experiences and needs of members of these equity-deserving populations.
So to meet these objectives, CCSA conducted a qualitative participatory research study that was aimed at understanding the impacts of virtual care on service access and service experiences from the perspectives of members of equity-deserving population who use substances. And this study also had the important objective of empowering members of this equity-deserving population in suggesting policy and practice recommendations to improve their virtual care experiences for both substance use and mental health. So I want to emphasize that these objectives were equally important in the study, and you'll see that the rest of our presentation will really draw on participants' perspectives and recommendations for service provision. So now a few words about the method. So This was a qualitative study, so that means that we conducted focus groups and interviews with members of equity-deserving populations. So the study took place in the province of Newfoundland and Labrador. Unfortunately, we could not recruit participants in Labrador, but we were able to meet with members of equity-deserving population from a wide range of regions of Newfoundland, including rural and urban areas. So for a total of 40 participants that took part in in-depth interviews and focus groups. So the participants were recruited in community-based services, which can be, for example, harm reduction services, peer support groups, or even outreach services. And during the interviews and focus groups, so participants were asked to share about both their experiences with virtual services, including the different services they used, the ones they would like to access, and as well what they recommend to improve the services and make them more in line with their realities and their needs. And finally, the focus groups and interviews were transcribed, and we analyzed them using a thematic approach.
So a little bit about the participatory study approach. The expertise of people with lived or living experience of substance use was included in all stages of the project, from the definition of the study design and objectives to the collection and analysis of the data and the development of this report and the presentation you are seeing today. The study was designed based on guidance from 6 partners with lived or living experience of substance use from CCSA's Lived or Living Experience Working Group. Following their guidance, CCSA hired a person with lived experience to lead participant recruitment, focus groups, and interviews. And I happen to be that person with lived experience who was hired to do this. Throughout the collection of data, I met with the other people with lived living experience to debrief and gain their insight and support throughout this process. Myself, Lise, and Chealsea were all involved in analyzing the data and the production of the final report. Where possible, we have all been involved in presenting the findings to various groups. One of the objectives of this study was to empower participants through policy and practice recommendations. And so we will get more into that as we continue. Next slide. So what are some of the benefits of a participatory approach? Well, we found the objectives, materials, and end products were actually more in line with the realities of people who use substances, because their voice and expertise was so crucial throughout this process. The researcher with lived experience, myself, leveraged my knowledge of local services to recruit participants and collect data. So being a person who's had to use all these services myself for my own substance use issues in the past, and some currently, I had easy access and relationship with these service providers and networks of, as Lise had mentioned, outreach places. I was able to, I already had kind of that relationship, so I reached out to their service providers requesting assistance through posters. I also had a phone where participants could call me directly and ask about the interview or focus group process. So that was really beneficial. This approach offered a safe and stigma-free space for participants to share their experiences. Many participants felt empowered by this approach in being able to have a voice into the things that are affecting their lives on a daily basis. And also seeing that someone who's been in their shoes is now part of a research project was quite inspiring to some folks. I remember an experience where a participant came in and sat down at the focus group, and I had introduced myself as someone with lived experience, and her shoulders were up by her ears and they just dropped down like, and afterwards she approached me. She said, "I want you to tell your boss that it's really good that you were able to do this interview. I felt like I wasn't being judged." And even as well-meaning as everyone in this field is, there is just a barrier that exists when people don't feel like you understand where they're coming from. It can make it not feel safe for them. So this approach really created safety for our participants, which I loved being a part of. And finally, the analysis we did together as a team really enriched the interpretation of data, because there wasn't just one person analyzing the data. It was, you know, a collaborative effort and many different perspectives and viewpoints that we all brought together in what you see as the findings in this report, which we're going to talk about now.
Yeah, sure. So the findings, finally. So first, we were interested in understanding the impact of virtual care on service access for our participants. So here, the key finding is really that virtual care has real potential to increase service access for equity-deserving populations, but it can still remain out of reach for many members of these groups. So, in terms of benefits for access, so virtual care can really fill service gaps, and here, service gaps, especially in rural areas. We had several participants from rural areas who had no access to in-person services, for example, no access to a doctor for prescribing medication for opioid use disorder, for example, and they were able to access providers that were living in different provinces. So this was really a gain in access for these rural participants. Virtual care could also reduce the burdens of treatment on people's daily living and enabling them to focus on other aspects of their lives, for example, work or family or childcare, and not having to organize all their day-to-day life around getting treatment and being at the doctor's waiting room and having appointments, for example. So virtual care was really described as more convenient for that, and as well it could reduce mobility-related barriers, especially for participants who had a chronic health condition. And like you can see in this quote from someone who lives with chronic pain and who had really better access, like more convenience of access with virtual care. And regarding the barriers, so participants described healthcare system and provider-related barriers. So this could be related to the lack of resources of healthcare services to really make virtual care available, and as well sometimes lack of skills of like technology skills of some providers who were not able to effectively implement virtual care. We also had, of course, participants also had technology-related barriers for themselves. Some of them didn't have access to the internet or a device or a phone or a data plan. So this was really a big barrier for many of them who had, for example, to ask to borrow a phone from a family member, for example, and didn't have full access to this device to really go to their virtual appointments. and some of them could stop using virtual care because of these barriers. And digital literacy was also an important component of that. And finally, inequities accessing information about virtual care, because some participants didn't even know that some virtual care services existed and were available to them because the information didn't go to them.
We also looked at the impacts of virtual care on relationships with providers, and one of the key findings here was satisfaction with virtual care providers improves. The relationship improves when providers show compassion and allow patients to choose their preferred care options. Several participants found that virtual care offered less opportunities for emotional connection. There was just, we heard over and over again from participants that while there were lots of benefits of virtual care, if it didn't have the same, eye contact, especially a lot of folks were only given the option of using the telephone with their providers, and this lacked, this made it hard to maintain that relationship or connection. And with providers changing so often, it's even more difficult if you're meeting someone for the first time and disclosing your, vulnerable information over the phone. So many participants preferred to at least be given the option, like you can see in the impact quote here, at least be given the option of FaceTime or Zoom, whatever platform that is being used by that provider, to at least have that face-to-face conversation when you're talking about your health. A lot of folks just felt like they were someone on the other end of the line to kind of, okay, what's your dose? Is it okay? Okay, call back in 2 weeks and click. Like there was no, how are you doing today? Like, what's it been like for you in this pandemic? There was no conversation in a lot of cases. So in-person care was preferred for issues requiring physical examination or diagnosis. We heard from participants that they didn't feel comfortable describing, say, an infection over the phone to a doctor when they shouldn't be expected to have the right words to describe what this infection or abrasion might have looked like. And they felt their doctor should have offered them the opportunity, the choice to go in person. That would have made them feel a lot safer, knowing that a physician actually looked at the issue and provided a diagnosis and treatment. Many participants preferred virtual care for the day-to-day prescription renewals, minor aches and pains, issues that came up, especially with, the frequent appointments needed for OAT. Patients really benefited from being able to do that virtually and not have to disrupt their daily routine like Lise talked about, and having to address those barriers of transportation, taking time off work, childcare, etc. And we also looked at impacts of virtual care on stigma experiences. Go to the next slide. Thanks, Lise.
Sorry about that.
That's okay. We found here that virtual care is a viable alternative to in-person supports and services among people who have experienced stigma accessing care. Participants throughout this, though this wasn't a research study on stigma experiences, it inevitably came up with almost every participant. They wanted to report and share on their stigma experiences by the healthcare system. And they also expressed in relation to virtual care, because of that, some of them were relieved that they didn't have to go sit in an office and experience some of those negative stigma experiences all over again. And for some, it prevented them from accessing in-person care again. So we did find that was a huge benefit to virtual care, that it can minimize stigma associated with the use of in-person substance use services. Some folks felt confidentiality of virtual care was a little, untrustworthy. It remained a concern for some participants, especially when we all went into lockdown. And, even now we have providers working from home and you can see pictures in the background. So participants felt like, are their kids home? Is their spouse going to walk in any minute? And that was a little unnerving. So that's, worth noting for clinical implications and practices to make sure it's a safe space. We heard from folks that often felt isolated with their substance use issues, that virtual peer support kind of exploded with the onset of virtual care. And in a peer support, like, folks spoke really highly of being able to access peers from all over the world and create meaningful connections that way when they were feeling isolated. And many continue to use those peer support platforms today, whether it be a 12-step peer support, or we heard about all kinds of interesting chat rooms and online networks where people could connect and be themselves and get support. So then I think the most empowering part of this study was then hearing recommendations from our participants on how to improve equity in virtual care. The key recommendation that I'm going to focus on is they want to involve people with lived or living experience, in developing, delivering, and evaluating virtual services. This theme was right throughout the questions. Most people were quick to say, well, ask us, you're developing programs for us. Why don't you? This is great that you're doing this. So I think this needs to be a regular practice. And this applied with their own agency and autonomy in accessing substance use care virtually, and being able to choose how they did that. So like I mentioned earlier, like, if they're really concerned about something, having the choice to say, no, doctor, I really need to come in and see you. And that's what'll be best for me, and having that option. But then also being able to cancel an in-person because you don't have childcare, but not having to miss your prescription renewal because of that, being able to still access a phone appointment. So those are just examples of scenarios that would cause, that they felt there needed to be some flexibility to give them that choice. They also felt that in all our service delivery for virtual care, recognizing experiential expertise was vital. And to do that, service providers would need to hire people with lived or living experience in those services to reduce stigma and increase a sense of safety. And then we heard a lot about service delivery development and evaluation. So people with lived or living experience felt they should be in the decision-making process to develop and improve virtual services and supports.
And participants also made other important recommendations on different aspects of virtual care. So first, the one we call knowledge as empowerment, they really emphasized on the importance of ensuring equitable access to information about the available virtual services. And they suggested a lot of advertising approaches that would be more tailored to really meet members of equity deserving groups where they are at. So these advertisement approaches ranged from online approaches like ads on Facebook or YouTube, or like the the places, online places that everyone uses, or even in-person approaches like having pamphlet in pharmacies, for example, and like making sure that the information goes to the people who need it, and really using a wide range of concomitant approaches to make sure the message goes to the right people. Technology as a human right. So they really wanted equitable access to technology for all, and like as well to digital literacy. So training about using technology tools. And they insisted on the fact that these should be public policies and this should not be kept with like private companies, like for example internet companies that provide lower cost for lower cost internet for people with low income, because some people don't have access to these options, especially for those who have debts with these companies. So like the solution for them should come from the government and should come from public, really public policies. And they also wanted standards for quality virtual care, so providing services with sufficient funding, human resources, and training to ensure that virtual relationships meet really high quality standards, and including this compassionate approach to care, and taking the time with empathy, and making sure like so the provider is aware of the needs of equity deserving groups who use substances. And they also wanted access to timely virtual support. They recommended the development of low barrier virtual or hybrid services that could be available all day to provide immediate support whenever people need it. So now we'll talk about the implications for clinicians, policymakers, and researchers.
Thank you, Lise. So we'll start with our implications for clinical practice. So I think we've heard quite a few themes throughout, so a lot of these should be familiar by this point, but I think that one of the top findings is that we really need to lean into the needs of the people we're serving. And so ensuring that options for health services and supports for substance use are really in line with the preferences of members of equity deserving populations and are really responsive to those needs. So just ensuring that if folks want to have a mixture of supports, we want to be able to facilitate a situation where we can offer those supports, and we're really kind of meeting the needs and meeting folks where they're at. We also want to look at clinical training, specifically around raising awareness of substance use stigma and the systemic inequities that are faced by members of equity deserving populations. We know through the research that oftentimes sort of general physicians or even emergency physicians can be the first point of care for a lot of individuals who are struggling with substance use challenges. And those first few interactions are going to be key to helping that person kind of get into the space where they want to be and start to work on their wellness and explore what that might look like for them. And so it's important that we expand our clinical training in substance use beyond those who specialize in substance use care and addiction medicine. A lot of individuals in Canada struggle with substance use. And so we need to be opening up these conversations on a variety of bases and root that in training and education that really underscores the impact of stigma in the present moment, but on people's future wellness, and provide experts with tools that they can use to ensure that they're creating sort of that safe, supportive space, kind of like Jill mentioned when we were doing the research. I mean, we would like to replicate that safety and security in clinical settings. And so we'll have an implication a bit later on about how we might be able to do that. Providers also need to be given sufficient time, resources, and training to develop virtual relationships that are based and rooted in compassion. So this is kind of linked to the previous implication, but we know that our healthcare system is stretched and funds are difficult to come by, and physicians have a lot on their plates. And so I think a lot of the participants were aware of this, right? And so we want to be mindful that we can't ask service providers to do more if we don't offer them more supports and more funding and more training, because they're already stretched in some cases to their limits. And burnout is a real issue, especially when we're talking about frontline services for substance use and mental health support. So very important that we look at how we can increase that funding specifically around this need. So in terms of policy implications, we'll take it kind of up a step and talk about some of the system level kind of impacts and what we might be able to do to address these. So one of the first points is around developing quality standards for virtual care. So we know that there are certain ways that we can create supportive and safer spaces, and we can lean into what we've learned from folks who are accessing these services to create standards that touch on confidentiality, that are rooted in this need to be coming from a place of compassion and trauma-informed care. So maybe leaning into or thinking about creating standards to support physicians across the country and develop sort of that threshold for what quality means. Because really that is an important piece. It's not just being able to provide the supports and provide the services, but we need that to meet a certain standard. And in order to do that, we need to listen to the voices of folks who are accessing them. So we also need to think about what does quality look like, not just from a provider standpoint, but also from a patient or receiving end of that. To foster digital equity in health, it's also essential, and this kind of is a good segue, to involve members of equity-deserving populations in the decisions about the development, delivery, and promotion of care. So we heard from folks who are accessing services that they're not seeing the advertisements. They're not getting the information where they are congregating and where they would access it. They might not be hearing the information in a way that relates to them. So it's really important that when we're moving forward in this space, that we take steps to involve folks in this work in a very meaningful way, and meaningful in the sense that looking at the way we approached this study, but incorporating individuals from the beginning when we're having conversations about what they need, and really thinking about meaningful and thoughtful ways of embedding perspectives so that it's equitable and we're not extracting information from individuals and taking that and kind of doing what we will with that, but taking a very meaningful approach and ensuring that that comes from a place of transparency and communication and understanding. And lastly, in terms of policies, we want to make sure that folks have access to internet devices and training as a human right. If we're going to be, and this study shows that there is a benefit to offering a variety of supports, a mix of in-person, telephone, virtual, perhaps at the choice, and ideally at the choice of the individual accessing those services. But we can't facilitate that if folks don't have the infrastructure, don't have mobile devices, don't have cellular infrastructure in place in their communities. We know there's lots of places across Canada that are rural, remote, where that infrastructure is not where it needs to be, or access can be very dependent on the weather. It can change from day to day. So that's not going to be equitable if we're hoping to move towards more virtual services. We need to ensure that regardless of where you live, regardless of your socioeconomic status, regardless of your history, you need to have access to those things. So that would be a really good place to start if we were to move on this path. And next, we'll talk about the research implications. So, and I'd love to hear from my colleagues, Jill and Lise, on this as well. But in terms of the implications, the participatory approach we took here, embedding folks with lived or living experience from the onset of the project, really did help to bring forth unique insights into the experiences of members of these groups that folks outside of the space. I don't identify as someone with a lived or living experience of substance use. I can't, you know, I might not be able to relate or convey or understand some of the needs. And so by embedding a person who has gone through these experiences and can share in those experiences really did improve, I think, not only the findings of the work, but there's a lot to be said about the personal connections and the knowledge growth and empowerment that individuals who participated in the study had amongst each other. There was a lot of knowledge sharing informally during those sessions that that in of itself, they could walk away that day, maybe learning about a new service, learning about a new support. So there were actually some, I think, unique unintended positive outcomes as well that we found from this work that just highlights how much more we can do when we take an empowering approach to engagement that is rooted in sort of, again, that openness, that authenticity, and really being open to giving over power. I think that's a really scary thing. And a lot of, we come from a non-government organization and tend to be a lot of organizations tend to be risk averse, and it makes a lot of sense. But we need to be open and willing to giving over some of that power and trusting in different forms of expertise, including lived expertise, to help us create better solutions and have greater impact on our populations. So with that said, this is actually one of the first studies in the field of substance use to provide virtual care recommendations directly from the voices of equity deserving populations. So it's very exciting to be in this space. And I think we just hope that through this work, we can demonstrate why there's value and how other projects could maybe incorporate this approach. And while this study was conducted in only one province, we do really feel the implications are transferable to different locations and jurisdictions in the country. A lot of the major themes were not necessarily new, and we could go back and reference these in other national studies that focus on virtual care and equity. And so I think through Jill's efforts to kind of seek participants from rural, remote, urban locations in Newfoundland, I do feel as though we were able to replicate kind of very similar experience to other jurisdictions where, you know, we weren't necessarily just looking at an urban center. We did, and Jill especially did put in a lot of effort to diversify where we were pulling that information from. So we feel very confident that these findings can apply to spaces outside of Newfoundland. So with that, I just wanted to share that we have a couple resources available that go into more detail about the study and our approach today. So on our website, www.ccsa.ca, we have both a full technical report on this research. Going into the findings, you'll find some quotes from our participants in there, providing a little bit more kind of description and quality to what we spoke about today. And we also have a shorter policy brief that walks through sort of what providers, what policymakers, and those working in sort of the health and social service sector should know about this work. So that's available. Again, the link there is www.ccsa.ca. So those are accessible in both official languages. So you can feel free to download those and peruse our other resources as well if you'd like. So that is the last of our presentation. Jill, or excuse me, Lise, I think you'd like to go through our acknowledgements for this work.
Sure. Yes. So we would like to thank all team members and project partners, and especially our partners with lived and living experience who accepted to provide input and feedback and collaborate with this work throughout the study, and as well as our institutional partners who provided useful subject matter advice and expertise. So yeah, now I think we're ready for the Q&A. You can contact us at CCSA if you have any questions. And yeah, I leave it to the audience now.
Thank you very, very much. What an exciting presentation that touched on so many, just so many important issues. So thank you for that. I am turning on the ability for folks to unmute themselves. Please raise your hand if you have a question. I feel I have not so much questions as reactions. I am thinking about, yeah, you said so many important things that I'm freezing up a little bit on where to start. But I think one of the things that I wanted to talk about is you spoke, Chealsea, I think in particular, you spoke so much about the importance of avoiding tokenism, of meaningful involvement. And I wonder about how that plays out for you. Are you able to talk a little bit about maybe even just the logistics of how that works, like the people with lived and living expertise on your team, how their voices are prioritized and how they are empowered in what they do.
Sure. Jill, Lise, did you want to start with this one? Maybe Jill, if you want to talk about the approach and how we where we started from.
Sure. So I've been part of the Lived Experience Working Group at CCSA since 2019. The pandemic kind of put a halt on a lot of our activity, but we were sent out requests to engage on different projects. We felt we had, because let me say, every person who has experience with substance use doesn't always have the same expertise on different topics. So CCSA would put out a research topic or an idea they were needing assistance with or input on, and those of us on the working group who felt we had something to contribute we could contribute. We could write them back and set up a Zoom interview. So that's how this project started. Like, so it was very much in the beginning of, we have an idea, we want to research this, how do you think we should do it? So all of the ideas around the study design essentially came from those focus groups. Lise and Sue Craig was our knowledge broker at the beginning of the project. They met with me one-on-one, but I know they met with most of the 6 lived living experience partners one-on-one or 2 at a time. So it was very intimate. And I think that really provided a safe space to really share your ideas. Like, it could be, this is a new space. Like, I know it's been happening for a while, but coming from Newfoundland especially, it's really new to have a voice, like not just be at a table, but actually have input at a table. And so I felt like it was, we're here to listen to you, Jill, and all your ideas are valid and important to us. So really just setting up a safe space right from the beginning and validating some of the concerns I had around, meeting people in a vulnerable place and asking something of them. And so part of the recommendations was meaningful engagement also means, similar to meaningful employment, it means paying people for their time and not in gift cards, and it should match the expertise that's being provided, and being very flexible with times, and similar to what we heard in access to care, like working with people with living experience, have to be work around their schedules, and maybe there's some barriers there around technology. So yeah, CCSA is really good at when they ask for input on a project, it's like you can write a response or you can call me and share what you think of it. Like, it really allows for a variety of perspectives and background and experience to be shared.
If I can add that at the beginning of the project, when we started it, like we really needed input. Like we had a lot of questions and dilemma. So when when we met with when we met with all our partners with lived and living experience, they had solutions to all our questions that we found really difficult to answer, especially what's the best way to connect with members of equity deserving groups, what should we ask them and how. And so they had very, very simple answers to all these questions, and I can't this collaboration, without it, the project would definitely not have been the same, and even not happen at all. So I think like this collaboration from the beginning to the end was key to the project, and we really tried to provide opportunities for the different partners with lived and living experience to contribute at different steps, like even during data collection, where they could debrief with Jill, having this safe space without staff from CCSA to talk about the experience conducting interviews and focus groups. So we really tried to provide opportunities to contribute throughout the project, and I think the feedback that I had from the 6 partners was that it's really important for them to just not be consulted at the beginning or just review some documents, but have news, being in the loop all the time, and having opportunities to contribute from the beginning to the end. So that's what we tried to apply to this project.
Yeah, it's really wonderful, and it also kind of beautifully mirrors, in a way, your study results, where it's like we need options, like give us the give us flexibility so in the case of the study, in how we contribute, in how we participate, give us options in how we access care, give us the infrastructure that we need in order to access care. So I'm just sort of finding a beautiful parallelism in that. A question from Solange in the chat here. From a clinical perspective, were the research participants able to continue to access a similar virtual service after the research was completed?
I think I'm not sure I totally understand the question, but some participants already had access to the virtual services that they needed. So the study didn't change anything in that, but some others who did not have access or who did not know about the services could actually get some better access with the study, because there was some information sharing, and we also shared Jill also shared some resources, local resources. So I think the study could provide some access or even some ideas on how to access for some participants, but I'm not sure that this was really the question. Perhaps Jill and Chealsea, you would like to add something?
Solange, I think what you may be asking is, because we're framing it as if, and it was a very safe and supportive environment when I facilitated the focus groups. But as Lise said, it was often, what made it so safe is it was in an environment they were already accessing services. So in focus groups, there was often people who knew each other, and they continued that. And then when I did one-on-one interviews, I was able to provide, crisis line numbers. Yeah, so we weren't the service, I guess is what I'm trying to say.
Solange, did you want to follow up or give any more details about your question?
No, I think you clarified it. Thank you. I was implying whether you had actually, I didn't realize there was not like a new service provided. It was more creating awareness. I was just thinking, like, since there's such a service gap, was there leaving like a greater need after the research? But I think you've responded.
Thank you so much. I am really interested in, and I actually forget which one of you said it. I think, but I loved the phrase. I think it was the inevitability of talking about stigma when you're like, even though this was not a project, a research study into stigma, but of course it comes up. And you raised some interesting points that I actually hadn't considered that make a lot of sense to me. One thing that you mentioned was just the issue of confidentiality. My immediate reaction was, well, you know, it would be better confidentiality because you don't have to go out there. You're not at, you know, an OAT clinic or whatever and having people see you there. But the point of, you don't know who's behind the camera. Like it's a really interesting point, because that could have real consequences. That's something that would really matter. I wonder if there were other ways that that issues of stigma came up just in the conversations that you had in the focus groups or in your analysis.
I think of one participant who's, I don't think I'll ever get her out of my mind, but she just kept saying, and she had solutions, which I loved. What I loved about this study, it wasn't just asking people what the problems are, it was, and what can we do about it? And then, so it left people feeling very invigorated. Anyways, this one person talked about just the way they were spoken to when they presented to emerge. And she said, I felt like shit on the bottom of someone's shoe. And it was just, it was really impactful. But her recommendation in, you know, relationships with virtual or in-person providers was that there be some kind of a line, like a tip line, not a tip line, like she didn't put it like we need to report all of these physicians. She recognized that, like Chealsea pointed out, the system is stressed and sometimes we're not being our best selves because of that. And she recognized that there needed to be more support and better, you know, management. And but she thought people with living experience could provide a support to providers by having a place where they could provide, you know, let them know this really hurt me, you know, in a safe, anonymous way, that when you said this, like, it really hurt me. And I would prefer if you referred to me this way, or maybe just treat the issue I'm presenting with that has nothing to do with substances rather than point out that I use substances.
What, I mean, as you say, that quote is so sort of punchy and heartbreaking and awful. And I'm wondering, I know we're coming up on the end of the session. If any clinicians here, like how would you receive that? What would that be like for you? If you were to receive anonymous feedback or you know, feedback about, because I think so often, like I'm quite sure that the vast majority of the time it is not intentional. Like people are not intending to do harm, but it happens, right? It happens. With the best of intentions, it can happen. Patient advisory committees can also be very helpful for that, especially facilitated by someone with lived experiences. What a great point, Karen. That's very true. And I don't know how much that's embedded in services yet, and perhaps more than I think, but I don't think of them as being super common across the board. Does anyone have any experience to that? Yeah, Karen, not as much as they should be. Yeah, I think that's true. I think that's definitely true. Well, listen, it's 2 o'clock. I'd like to thank all of our speakers for a wonderful presentation. Thank you, folks in the audience, for being here and for your engagement. I've put the link to the feedback survey in the chat. Please do fill it out if you have a moment. We're on a half-hour break now until 2:30, when we'll be meeting for the final session. And yeah, once again, thank you all so much.
Thank you.